introduction, and thank you to the planning committee for this. Thank you, all of you, for coming here this early morning and allowing me the pleasure of teaching you some little tidbits about cardiovascular disease. The goal for today was really just to understand how there are different checkpoints in a woman's life and how those checkpoints can impact our overall health. But it can also impact our health either positively or negatively, but understanding how they intertwine can make the biggest difference. So to get to the first topic, I think it's important that we ask the question though, why not only is cardiac disease the leading cause of death for both men and women, but actually what is heart disease? Because I think it's first important to understand what it is before we delve into the why. So when we think about the cardiovascular system as a whole, it affects the heart and the blood vessels. This graphic here gives a nice depiction of all of the different types of areas of the heart that are impacted, ranging from the valves, which I think about like doors that open and close, that sometimes can be thickened or sometimes may not close completely, so that leads to leakiness. Or it could be the blood vessels where maybe they become aneurysmal or enlarged. Or could it be the electrical system in our heart where cardiac arrhythmia can occur? Could it be the lining around the heart where inflammation can sometimes develop in the setting of pericarditis? Or could it be that the heart itself is not beating as well as it should, a condition called heart failure? Or is it possible that the heart is not relaxing as well as it should, which is another type of heart failure? For today's topic, though, our focus is really going to be on coronary artery disease, where fat deposits in the arteries and the vessels. And that, to be frank, is what's driving the leading cause of death in women. And when it comes to heart disease, among females 20 years of age and older, and these are statistics between 2017 and 2020, nearly 45% had some form of cardiovascular disease. And this is why, for us in the preventative world, Dr. Chaub and myself, our focus really is women during their reproductive ages. Because as it stands right now, the group that's having the highest rates of premature death, but very preventable death, are women between the ages of 35 to 54. However, despite that, only 44% of women are actually aware that heart disease is their leading threat. And this has significantly declined over the past decade. About 10 years ago, about 60% of the population knew that heart disease was their greatest threat. And now, when the American Heart Association released this statistic, they actually saw that the population that knew the least about the greatest threat were Black women, Hispanic women, as well as younger women in that age category, 35 to 34. This translates into the fact that heart disease is going, as you heard, under-recognized as well as under-treated. And there are lots and lots of startling gaps that lead to this. The biggest one I would say is the fact that only 38% of cardiovascular research participants are women. Our goal is that should be 50% women, 50% men. Furthermore, when you think about medical research that's specific to women, only 4% of clinical trials fall under that. And the vast majority are on oncological conditions like breast cancer, uterine cancer, or ovarian cancer, which although are very impactful, we know most women are not dying from that. I also want to pause to highlight the fact that there's lots of data and research that suggests women have a tendency to have better health outcomes when treated by female physicians like myself and Dr. Toad. However, only 15% of cardiologists are actually women, and if you think about women of color, it's even less. So there's a big strive for us with our medical societies to really present to younger women out there that we need more of you in our field because you're going to help us all collectively. And it's not uncommon because of this that women spend 25% more time in poor health than men and have significantly more medical visits and out-of-pocket healthcare costs. And all of this is what translates into the fact that 1 in 4 deaths a year from cardiac disease are seen in women, making it the #1 cause of death in women. This is why we wear red today. This is why we have February, which is Heart Month. But another pivotal thing in February that we highlight is also Black History Month. And it's really important for me as somebody who comes from a community but also dedicates a big portion of my practice to a community to highlight the fact that the greatest group that's dying, particularly in women, are Black women. Whereas 1 in 4 women in general die of cardiac disease, more than 1 in 2 Black women have some form of heart disease. And as Black women, there's an even higher chance of dying especially at a younger and younger age. To put that into perspective, when we think about a Black female above the age of 20, nearly 60% have some form of cardiovascular disease. The biggest driver being high blood pressure, which is a pretty common and also modifiable or reversible risk factor, and we'll get into that. Before we get into the risk factors though, I think it's important that we better understand the signs and symptoms, because there are signs and symptoms that are very common in both men as well as women, but then there are more subtle signs that are more likely to be seen in women. And when we think about the most common symptom of a heart attack for both men and women, it is chest pain. It's that pressure feeling in the center of your chest, kind of like you see in the Hollywood movies where you feel like an elephant is sitting on your chest. It's brought on sometimes by exercise or activity or stress, and it's usually relieved by rest. But then we have in women, more commonly, they may experience less obvious warning signs. They may feel nauseous, they have vomiting, they may have jaw, neck, or upper back pain. They may also notice pain or pressure in their lower chest or upper abdominal area. They may feel a little winded or short of breath. They may have a feeling of feeling very faint, like they actually are going to pass out. And sometimes the most common overlooked sign is extreme fatigue. So that fatigue that doesn't go away even if you get the appropriate hours of sleep that you're expected to get, even if you change and modify your lifestyle. That could be a warning sign, and that's something that we as women especially shouldn't be ignoring. Now that we understand the signs and symptoms, I think it's also important to understand the risk factors, because there are several risk factors that impact us as women more so than men. When we think about the more common ones that most people are aware of, those are the risk factors that can be managed. So high blood pressure, smoking, high blood cholesterol, lack of regular activity, obesity or being overweight, or diabetes. And although these, of course, impact both men and women, when you look at each and every one of them, they impact women much greater. So for those that smoke who are females, you're at about a 25% greater risk of dying of cardiac disease, even if you smoke the same number of cigarettes for the same duration. When you think about high blood pressure and high cholesterol, women are often less likely to be as aggressively treated for it with medication. A lot of that has to do with the biases that exist in healthcare, which we'll be getting into. But even when you think about lack of regular activity, obesity, and being overweight, a lot of that disproportionately affects women as well, just as diabetes does. So although those are shared risk factors with men and women, they do impact women much greater than they do men. But then we have risk factors that we can't control. Age, right? We can't control getting older. And when we think about the age that puts us at a heightened risk as a female, it's really any female above the age of 55. Gender, of course, because women have a tendency to have more specific risk factors, which we'll be getting into in the coming slides. But family history is another factor that we can control, but such an important factor that we should know about. We should be asking each and every one of our first-degree relatives, our parents, our siblings, our children, what is their cardiac history? Because if they have a cardiac history, you're more at risk of having a cardiac history. We also know that, of course, having a previous event like a stroke or heart attack could be a contributor. And lastly, race. As I showed on the slides, Black women are dying at the highest rates, but when we think about race, it's not the genetics or biology of it, it's the social aspects, those social drivers, which we'll also be getting into. But then there are risk factors that are more impactful or unique in women. So age of first menstrual cycle, if you had a menstrual period that began before the age of 10 or actually occurred later than the age of 15, that could be a risk factor for future cardiac disease. Age of menopause, huge. When we think about menopause, those that undergo menopause either premature, which is before the age of 40, or early, which is before the age of 45, that can also put you at a heightened risk of cardiac disease. The average age of menopause in the United States is about 50 to 53, so anything predating that can put you at a higher risk. When you think about also specific to women, polycystic ovarian syndrome, which is a metabolic condition that often causes dysregulation of our ovaries and sometimes puts women at more risk of infertility, puts women at more risk of insulin resistance. That too could be a risk factor for cardiac disease. And anything that increases inflammation, because when plaque first develops, it's all through an inflammatory process. So conditions such as lupus, rheumatoid arthritis, that are autoimmune conditions which disproportionately affect women, particularly women of color, that too can put you at a higher risk of heart disease, as can chronic migraines and recurrent miscarriages, which we often don't know the cause or underlying reason for. And in speaking of pregnancy, there are so many things that can impact us during one's pregnancy. A lot of these conditions fall under this umbrella called adverse pregnancy outcomes. These are high blood pressure during pregnancy, including chronic high blood pressure, gestational high blood pressure, which is when you're diagnosed with blood pressure during pregnancy, or preeclampsia, when the blood pressure does occur during pregnancy where it becomes elevated, but it's also associated with evidence of other organs being overstressed, be it the heart, the kidneys, the brain, the liver. Understanding if you have that, also coupled with a few other adverse pregnancy outcomes like gestational diabetes, preterm delivery, placental abruption, which means that there's a tearing of the placenta very prematurely than one would expect, and also having a child smaller than the expected age. All of these could impact not just your current pregnancy as well as your future pregnancy, but your long-term cardiovascular risk. And when you think about it, these account for 1 in 5 pregnancies. So it's a high proportion, right? 20% of pregnancies are impacted by one of these 5. And understanding your pregnancy history can make a big difference. And it is why, as I said before I started this lecture, knowing these different checkpoints in our life can really dictate our future cardiovascular health. Because there are stages in a woman's life where caring for her health and well-being are critical. I'm going to enter a few of them, and we're going to start with this slide and then delve a little bit deeper into it. But as I noted, and as it pertains to pregnancy, unfortunately, heart disease is the leading cause of maternal death in the United States. It's for that reason I have dedicated a big portion of my career and my research to mitigating that and preventing that. It can pose a threat to women's hearts, not just during pregnancy, but also later in life. If you have any of those adverse pregnancy outcomes, those risks can be up to 4 decades after you actually had that pregnancy. So telling your physician a really detailed pregnancy history may help them better determine what testing you should actually be undergoing. We talk about menopause and we're going to go deeper into it, but as it pertains to heart disease, the risk rises for everyone as they age, but for women, the years leading up to or after menopause are that critical time to care for their health. I bring up breast cancer not as a condition that will impact each and every one of us, but as a fact that we have a preventative way of ensuring that if we're going to have breast cancer, we can get diagnosed early. That's getting your mammograms once a year, right? So after the age of 40, all women once a year should be getting mammography. And then the mammography has really made such a high survival rate with breast cancer. But I bring up breast cancer because there are several women out there who have experienced it. It impacts 1 in 43 women from the ability to die from it. However, there's high survival rates. And there are some treatments, such as chemotherapeutic treatment or radiation therapy, that are so good in removing that cancer, but it can also impact negatively the heart. So women that are survivors of breast cancer, without a question, should be seeing cardiologists to make sure that their heart is under good control. But as mentioned, we're going to delve deeper into these topics. So let's talk about those pregnancies. When you think about the long-term cardiovascular risk, any female that has had preeclampsia, gestational diabetes, which is diabetes during their pregnancy, or other adverse pregnancy outcomes, they're at a 2 to 4 times higher risk of having high blood pressure outside of the pregnancy. They're also at an increased risk of heart disease as well as heart failure, and the onset is earlier than the average population. Disproportionately, these adverse pregnancy outcomes do impact Black women, making it extremely important that Black women, but women overall, understand how to care for themselves and their baby. I volunteer, as you heard from Dr. Cobb, quite a bit with many of our cardiovascular societies, and the one that's the most impactful for me is the Association of Black Cardiologists. This QRS code here, feel free to take out your phones and enter it, because it brings you to the Association of Black Cardiologists website and the campaign that we created, which is We Are the Faces. Specifically, We Are the Faces of Black Maternal Health. In this website, there are infographics where it gives you pointers on questions to ask your healthcare professional in the setting of you thinking about becoming pregnant, during your pregnancy, and after. Questions about, should I be on a low-dose aspirin because I know I have risk factors that may increase my risk of preeclampsia. Lots of data to support low-dose aspirin can lower that risk. Questions about what should be a healthy weight for me to gain during my pregnancy. Questions about, should I breastfeed? Lots of data to support a wonderful impact from a cardiovascular perspective on breastfeeding up to 6 months after delivery. So lots of value, but this national campaign is really breaking ground and trying again to reverse the statistics, the staggering statistics that we're seeing when it comes to maternal health, specifically in those more marginalized communities. Now, transferring this to a different topic, we're going to talk a little bit about menopause as well as perimenopause. So perimenopause is roughly the years leading up to menopause. And how we define menopause is you have 12 consecutive months of no menstrual cycle. Once that happens, you are now in menopause. The day after, you're postmenopausal. And it's a critical window for prevention because when we think about it, the risk accelerates, not just during menopause, but also again in those years leading up to it where there are hormonal fluctuations. And perimenopause often can span anywhere from, when you think about it, 4 to 10 years before menopause actually comes on. But why that risk accelerates is that natural drop in estrogen can affect the heart and blood vessel health. It can cause weight shifts, which a lot of times the weight goes to the belly, and when it goes to the belly, it puts more strain on the heart. It causes more inflammation, which gets to the heart as well. Oftentimes during perimenopause and menopause, your cholesterol and your blood pressure can rise, and the heart and blood vessels naturally age faster during this time as well. And research shows that women who experience early menopause, again, before the age of 45, especially when they have vasomotor symptoms that are untreated, those hot flashes and night sweats, they are at a significantly greater risk of heart disease and stroke. And this is extremely important because now cardiovascular physicians are in the realm of women's health. Hence the reason we have to be working collaboratively with the primary care doctors, the family medicine doctors, and your OBGYNs. And I want to raise the fact that new research also suggests that women of color have a tendency to enter perimenopause as well as menopause at earlier ages than their white peers. They also have longer transition periods, and they experience more intense hot flashes along with vaginal symptoms. And despite now knowing that treating those hot flashes, treating those vaginal symptoms, treating those night sweats can theoretically lower their risk of cardiovascular disease, Black women who qualify based on their risk profile are 5 times less likely to be placed or recommended for hormone replacement therapy than white women. A lot of this, again, as it is in healthcare, is due to racial disparities, either be it in access, provider biases, lack of research, and that's the biggest one, the lack of research, because there's very, very limited research in general on menopause, but menopause specific to the effects of Black women. One thing I was extremely excited about at the end of 2025 was that finally we're having discussions about women's health and menopause, especially in the realm of cardiovascular disease. One pivotal thing that occurred was that the FDA in November of 2025 actually ended a 22-year overly broad caution, which is a black box warning on menopausal hormone therapy. This originally was put in 2002, and the warning came from a very often considered flawed women's heart study where they initiated hormone therapy on women at the age of 63 or higher, over 10 years from when they actually went into menopause. And what this highlights is that we now have data to support There's a timing approach. So usually, if you're within 10 years of onset of menopause, if you have those vasomotor symptoms and your cardiovascular risk is low, but your other risk profile is low, meaning you don't have things that would prevent you from being a candidate for hormone replacement therapy, such as known coronary artery disease, breast cancer, or other high-risk factors, considering the use of hormone therapy could be beneficial for you. And the removal of the black box warning was the first step that the FDA did, but they also approved a generic version of Premarin, which is a vaginal estrogen, which does not have any restrictions, even in our higher risk populations. They also approved the third non-hormonal option for hot flashes for women who can't use hormone replacement therapy. So those women with a history of breast cancer, those women with coronary artery disease who are suffering and having those hot flashes and night sweats, now there are at least options out there that are non-hormonal that one can consider. And this again is exciting because it really is paving the way that when we focus on women and do the actual research, the outcomes are going to be better. Now, pivoting to breast cancer, why I also wanted to bring it up, not just in the setting of the treatment of it, is that when we think about breast cancer survivors, the number one thing that they're dying from is heart disease. And a lot of the data is compelling because not only are some of those treatments that cure their cancer, like chemotherapy and radiation therapy, posing some strain and stress on their heart, but they have a lot of shared risk factors: breast cancer and cardiac disease, obesity, being inactive, the process of aging. All of those are risk factors for both, and a lot of it has to do with that pro-inflammatory driver. When we think about Black women, they're more likely to have an earlier age at diagnosis of breast cancer, present at later stages with breast cancer, and are also at a higher risk of more aggressive triple-negative breast cancer, making it a little bit harder to manage. Black women are placed also at the greatest risk for early death, and data has suggested that racial discrimination on the job, in housing, and from the police were 48% more likely to develop breast cancer than those who reported no incidents of major discrimination. It's for that reason that Black women have been shown to have a 3-time higher risk of a weakened heart muscle after the use of chemotherapy or radiation therapy agents as compared to white women. Black women are also more likely to be predisposed to risk factors which play a role, such as high blood pressure, genetics, as well as social factors. And again, this is for our eyes to better understand, again, the disparities that exist, but understand that even with these chronic medical conditions, there are ways to reduce our risk. So how do we reduce that risk? And these are our last few slides that we're going to be delving deeper into. Well, the first way is understanding life's essential 8. This was a amazing creation by the American Heart Association, where we talk quite a bit about the 8 steps women can do to lower their risk of cardiovascular disease, even if they've already had a cardiovascular event. And we're going to delve into each and every one of them. Step number 1 is embracing a healthy eating pattern. This is where we should be enjoying healthy foods like vegetables and fruits and whole grains and beans and legumes, nuts, having more of a plant-predominant protein diet, having lean animal protein and skinless poultry, fish, and seafood. This is where we should be limiting things like drinks that are sweetened, alcoholic beverages, sodium, red and processed meats, or refined carbohydrates like added sugar and processed grains and foods. And this is where we really should be breaking up with trans fats, as well as partially hydrogenated oils. And a lot of that is seen in commercial baked goods as well as fried foods. This is also where we should be moving more. The American Heart Association suggests that as long as we're getting in at least 150 minutes of moderate aerobic activity, or 75 minutes of vigorous aerobic activity per week, it can make a huge difference. And I want everyone to realize that moderate aerobic activity is equivalent to walking at a fast pace. So we can make a huge impact on our cardiovascular health just by adding those extra steps. It's also important to acknowledge that strength training is also really important, where the muscle strengthening activity, using resistance or weight training at least twice a week could be impactful. We want to ensure that as we're doing each and every of these activities, that it's important to realize you don't have to reach 150 minutes right off the bat, right? If you start maybe 30 minutes a week, increase that the next week to 60 minutes, and increase that the next week to 90 minutes, right? Gradually increasing your time, increasing your distance, increasing your amount or effort over time will go a long way. Similarly, don't be toxic, quit tobacco. Right now, when we think about it, cigarette use is unfortunately one of the more common modifiable risk factors for cardiovascular disease, and it is disproportionately impacting younger adults, even our children. When we think about it, if somebody is smoking, within 1 year of quitting, your risk of heart disease goes down by half. And I tell my patients that because I have many patients out there that have smoked for several decades, and they think that, quote unquote, the damage is done. It's not. Quitting at any moment in your life can significantly reduce your future risk of a cardiac event. Smoking is, again, the most preventable cause of death in the United States. It's linked to about a third of all deaths from heart disease, and of course we know the linkage between lung cancer, that's about 90%. Smoke damages our circulatory system, it increases our risk of multiple diseases, and it's not just cigarettes, right? We have to think about the e-cigarettes, electronic cigarettes, the tobacco products that include toxic chemicals, as do the smoke, the liquids, and the vape. So vape is probably the biggest concern, especially for the teenagers and the young adults out there. And roughly 40% of US children ages 3 to 11 are also being exposed to secondhand smoke. If we can inhale those fumes, unfortunately, it's also impacting our circulatory system as well. Sleep. So we want everyone to sleep like a star. There's a lot of benefits of getting in good sleep. There's healing and repairing of cells, making sure that your immune system is stronger, improving our mood and our energy, having better brain function, being more alert, having a good memory, reasoning, problem solving, and then the impact of having poor sleep is really, from a chronic perspective, very, very impactful. It can increase your risk of cardiovascular disease, cognitive decline and dementia, depression, high blood pressure, blood sugar, and cholesterol, as well as obesity. How we think about sleep is, number one, it is a vital sign for us, and we should be getting in at least 7 to 9 hours of sleep per night. Data supports anything less than that or anything more than that can increase our risk of heart disease. And it's also important to highlight it should be uninterrupted sleep, right? So figuring out ways to ensure that will go a long way. As will staying well within our weight. So balance is beautiful. This is where we reduce our calories coming in. This is where we increase our calories going out. Or this is where we have discussions with our healthcare professional about other modalities to help us with our history of obesity or being overweight. You heard from the CNO that there are medications out there, GLP-1 agonists. Those really have made a pivotal role in helping to expand our arsenal when it comes to the management of a chronic condition like obesity, which again, there is an epidemic of. But understanding what your risks are and making these little minor adjustments sometimes can also go a long way. And then there's knowing our numbers. So cholesterol control, it is important that you understand not just what your numbers appear, but what the target for you should be, because everyone has a different target when it comes to their cholesterol. So your HDL is your good cholesterol, your LDL is your bad cholesterol, and your HDL has a tendency to help your LDL from sticking to the arteries. And by doing that, it reduces plaque buildup. And this process will lower your risk of heart disease and stroke. Your triglycerides are the most common type of fat in the body, and then the total cholesterol is kind of a combination of all of those three. But again, everyone's cholesterol level will be very individualized based on their risk factor. If they have had heart disease and they have had procedures to repair their heart, if they have, for preventative reasons, been checking their cholesterol, or if they have a genetic reason that they're unable to remove their cholesterol, not just understanding your numbers, but asking your healthcare professional, what does my target look like, really will help you in the long run. And the same goes for blood sugar, where getting to know your blood glucose level is going to be important. Glucose is that carbohydrate and sugar in what you eat and drink. It turns into glucose in the stomach and your digestive system. Glucose can then enter your bloodstream, and once it enters your bloodstream, the pancreas usually releases a hormone called insulin, and that normally helps the body cells to take up glucose from the blood and lower your blood sugar. patients that have type 2 diabetes, when that glucose builds up in the blood instead of going into the cells, a lot of times it's because their body develops a resistance to that insulin. And it can't use it to ensure that the blood sugar is going appropriately into the cells that it needs to. Also, a lot of times the pancreas can gradually lose its ability to produce that insulin. So this is where oftentimes high blood glucose levels come into the mix, and that can unfortunately increase your risk of heart disease. I do think it's important to highlight that a history of gestational diabetes also increases your risk of diabetes outside of pregnancy. So regularly getting your blood sugar checked if you had gestational diabetes is also going to be important as well. And then I leave blood pressure for last because it is, again, one of the most common reasons that people have heart disease and die of it early. When we think about high blood pressure, it is a silent killer. That's what we call it. Actually, the American Heart Association, the American College of Cardiology, a few months back revised their blood pressure guidelines because of the fact there's such an epidemic of it. And the guidelines today really pinpoint that we should be educating our patients on what's normal. When you think about blood pressure, normal blood pressure should be less than 120/80. Anything above that is considered elevated up until we get to the first stage of high blood pressure, which is 130 to 139 millimeters of mercury over 80 to 89 millimeters of mercury. And there's a second stage. The second stage is we worry the most because that's when medicines without questions oftentimes need to be initiated. That's when our blood pressure is greater than 140/90. And of course, when the blood pressure is in that hypertensive crisis, meaning you have to go to the emergency department, you should be calling 911, especially in the setting of symptoms, that's when your blood pressure is greater than 180/120 millimeters of mercury. What's helping us right now better diagnose high blood pressure but treat it is empowering our patients to consider getting self-monitored blood pressure machines. And this is one thing that the guidelines did a really good job in emphasizing. There is a website called validatebp.org where if you go on that website, it lists all of the blood pressure machines that actually have been validated by the FDA. That means that they're working well, we know that they're working well, they've been approved. But it's also important that you acknowledge how your blood pressure gets checked in the office too. And not just in the office, but how are you checking it at home? So you want to take 2 or more blood pressure measurements at least 1 minute apart. The blood pressure should be done in a temperature controlled room because being too cold or too hot can actually raise your blood pressure. You want to make sure that you're avoiding caffeine, exercise, and smoking for at least 30 minutes before checking it, because all of those things can raise your blood pressure. You also want to make sure that your arm is supported at the heart level. It is, of course, best to use that left arm if you could. You also want to be relaxed, seated in a chair. You want to have your feet flat, your legs uncrossed, and your back supported for at least 5 minutes. And if you're in your clinician's office, you want to make sure you're not chatting away. I always bring this up to my medical assistant. I of course, love the fact that she talks to my patients, but can't talk to them when we're checking our blood pressure, because that unfortunately is going to raise it as well. Other things that can commonly raise blood pressure, though, is, of course, our dietary intake. Are we taking in too much sodium? Are we maybe not getting enough potassium or calcium or magnesium? Or are we having lower diet quality foods? Alcohol also can drive up blood pressure. This is why the recommendation by the American Heart Association is limiting alcohol intake to no more than 1 glass per night in a female, no more than 2 glasses per night in a male, and that usually is a 4-ounce serving, right? So we have to be mindful of serving sizes. But then there are non-dietary factors, our genetics, if we have obesity, if we have lower physical activity. Sleep disturbances, such as sleep apnea, commonly raise blood pressure, as does air pollution and psychosocial stressors. And I end with psychosocial stressor because the mind-heart-body connection is real. Research has suggested that women are more likely than men to experience symptoms of stress. They may feel symptoms more, or get more symptoms in general than men. Women are also more likely than men to be diagnosed with mental illnesses like anxiety and depression, and women are 38% more likely to have a cardiovascular event when experiencing high work stress. In fact, work stress is about as risky as that secondhand smoke. So risky that I was very privileged to actually do a research project with the then president of the American Heart Association, Dr. Michelle Albert, where we focused on something called the superwoman schema. This is where suppressing our emotions as women, having vulnerability resistance, manifesting strength, determination to succeed, and obligation to help others more than self-care. Think about what that's doing to our body, our sympathetic nervous system, our inflammatory system. And our focus was largely in Black women because disproportionately we see this. This is where higher rates of anxiety, depression, poor sleep, impaired immune system, having those cardiometabolic conditions like high blood pressure, high cholesterol, all of that leads to wear and tear on the body, it leads to exhaustion on the body, and all of that leads to premature cognitive and cardiovascular conditions. So I leave you with that, but I leave you with the understanding of there's other things we can do beyond just knowing what our risk factors are and focusing on cardiovascular, heart-healthy lifestyle measures. One is learning hands-only CPR. The data supports that too often women are less likely to receive hands-only CPR by bystanders. A lot of it has to do with their concerns about where do I appropriately place my hand so I'm not necessarily impacting and touching the female inappropriately. We see that even in communities of color, they're less likely to receive life-saving hands-only CPR. And 80, if not more, % of cardiac arrests are outside of the hospital. So this is going to be someone you most probably know. So learning hands-only CPR can be key. Invite a friend to join you in starting a routine to kind of regularly monitor your blood pressure and keep that silent killer at bay. Please, please, please schedule your annual wellness check with Dr. Doe. She, for sure, I'm sure, will go over all of these detailed risk factors with you. And lastly, understanding that stress is probably our biggest driver why these disparities exist in women, especially women of color. We have to put that cape down. We have to take a quiet moment alone to de-stress. We have to practice self-care or reach out to a friend or health professional because we know emotional well-being is just as important. And for more information, there is a website, which is thegoredforwomen.org. I also want to address that, and I'm going to open it up for questions in one moment, but I want to address that as you exit the auditorium today, one of my associations that I volunteer with, the Association of Black Cardiologists, was very gracious in providing you with their steps. So the American Heart Association has Life's Essential 8. The Association of Black Cardiologists has 7 simple steps, and the reason I thought it would be the most pivotal to share that over the American Heart Associations is that they talk quite a bit about how stress does negatively impact one's life, and it gives us some insight on how to have moments of de-stress, but like sound, real things that we can do on our day-to-day. So with that, I thank you so much for this opportunity, and I look forward to any questions you have.